Well, good morning. And I so wish I was in Alaska with you. I fully intended to be there. And then one of my chillins surprised me with some kind of an available week of vacation. So I'm here with Zoom, but I'm also very much there with you in spirit. I also am so happy that Meg Gaines is running the Q&A. First of all, she'll be able to ask the questions and do the answers as well, from my perspective. Meg and I have been friends, more than friends actually, colleagues forever. And when I say colleagues, she and I have been joined at the hip over several of the topics I'm going to discuss today. And of course, she's the godmother to both my children, more or less. So today I'm going to talk about careers focused on purpose. And I know that somebody's probably done an introduction. I'm a gynecologist. The greatest joy in my professional life has been caring for patients that are facing GYN cancers. And 15 years ago, I became the chair of Obstetrics and Gynecology at the University of Wisconsin. And part of my job, a very important part, has been to continue caring for patients with GYN malignancies. Now, I know the audience today is composed of patients as well as physicians, so I'm going to try to cater to both. And I do think this will be one of the more bizarre talks that you have heard in a while, but I'm giving this from a perspective of a mature age, and also I'm retiring in March. So I'm feeling somewhat sentimental and reflective on my career. No conflicts, no disclosures. And when I look back on the last 30, 35 years, there's been twists and turns. And that's what this talk is about. And the focus of this talk is on identifying your areas of interest and passion. I've already confessed that taking care of women with GYN cancers is my #1 passion. But also, what can dovetail into that? I've been very fortunate with what's appeared on the horizon in terms of taking a stance on advocating for women with cancer, GYN cancers, as well as other areas in women's health care. I've looked for opportunity and I've been given it, been a little crafty with that. And then also I've learned that lessons come in odd packages. So a little bit about myself. I went to college and medical school at University of Colorado, and then did my residency and fellowship at the Brigham and Women's Hospital in Boston. And then for 4 years worked at the MGH, worked at UVA for 14 years, and I've been at UW for 15. So my first job in Boston, I was there for 4 years after training, was really about solidifying my skills as a GYN oncologist, both with surgery, chemotherapy, palliative care. It was a formative time in my life because it was completely focused on patient care. I had no children. My husband was a resident. I never went home. It was perfect. No conflict. And I was fortunate there to have a chair who's represented here, Dr. Isaac Schiff, who I still communicate with by email every day because he was amazing. So what I picked up at this point in my career, the importance of mentorship and sponsorship, and that is relevant to everyone in this room. If you're a patient who has had or has a GYN cancer, your ability to help others facing the same issues is so much more than the physicians or other people in healthcare. And similarly, as physicians, any physician in the audience knows how important mentorship is. And then moving to the University of Virginia in Charlottesville, my husband finished his training. We needed to leave Boston because there wasn't a great job for him there. We looked all over. Long story short, we ended up at UVA, and it was good for both of us professionally. Beautiful campus. Sadly, it's been in the news in the last few years in a very negative way. But again, I had the good fortune of having a tremendous mentor there. He was the chair, Paul Underwood. And just as a funny little story, you know, it took a lot for me to get used to living below the Mason-Dixon line. And frankly, once I moved to Wisconsin, I realized, whoa, this is more my home than Virginia ever was. But anyway, when Paul who offered me the job, he called me Sugar. And that's kind of like, I didn't like that, even all those many years ago. Sugar, who the hell is Sugar? Took the job anyway, and then what I figured out was he was one of my very most important mentors and one of the biggest advocates for women. Lessons come in odd packages. So 2007, I interviewed for a job at UW. I'd never been to Wisconsin. My kids weren't sure where it was, which means I wasn't getting my money out of what I was paying for their education. And the dean that hired me was Dean Robert Golden, who Meg knows very well. And he's been my dean ever since I got here, and I've just been so fortunate with generous people around mentorship and advocacy for me. And he has made my professional career in Wisconsin just really, really fantastic. So that's a general outline. Now let's go to some twists and turns in my career. This article was published in the New Yorker, I don't know, early 2000s. And I used to read the New Yorker a lot, I don't anymore, but I read this article. The title's John Rock's Error, and it's by Malcolm Gladwell, the guy who wrote The Tipping Point, et cetera. He's a pretty famous writer. It's a picture of John Rock, big guy, broad shoulders, Catholic, went to church every morning for decades. And then at a certain point, he stopped going at all, which is another story. He was famous, cover of Newsweek. If Oprah had been around, he would have been on Oprah. So, John Rock, he was the man in Boston. He wrote the seminal article on ovulation, as well as the definitive article on the physiology of human conception. He figured out when women ovulated. He figured out how the whole issue with pregnancy and miscarriages and all that happened. And the science and how he did this is fascinating. I'm not going to go into it with you. He was in every big society in Boston. He was definitely the GYN doctor to the stars. Now, in the middle of all this work that I just briefly brushed over, he decided he wanted to work on birth control pills. You know, he had some, that's all I can say is I feel inadequate right now. But anyway, he had some collaborators. In early 1950, he figured out, they all figured out, they could block ovulation. Here's a picture of the Free Hospital in Boston, where he worked. This hospital was built for women with cervical cancer because they smelled bad, and they didn't want to have those patients at the Brigham and Women's Hospital, which just makes me angry. But anyway, the clinical trial for birth control pills was conducted there, 50 women, nobody ovulated. So that was good. Now, what needed to happen next was a bigger clinical trial. And it was a felony in Massachusetts then. Birth control was a felony. And so they took it, the medication, to Puerto Rico. He had a big trial, and nobody ovulated. So again, they had it figured out. And by the late 1950s, lots of women taking birth control pills for menstrual irregularities. In fact, the packaging said women will not ovulate while taking this drug. And then it was approved by the FDA in 1960. And from John Rock's article, I want to read this to you. In hindsight, in Malcolm Gladwell's article, in hindsight, it is possible to see the opportunity that Rock missed. If he had known what we know now and had talked about the birth control pill not as a contraceptive, but as a cancer drug, not as a drug to prevent life, but as one that would save life, the church might well have said yes. And obviously, the Catholic Church has not ever approved birth control, but once it was approved by the FDA, John Rock went to the Vatican, he went to Notre Dame, they had tons of conferences. It looked like the Catholic Church was going to buy into contraception, and then the answer was no, and he never went to Mass again. So that's the story behind John Rock. In 1961, the chair of OBGYN at Yale and the executive director of Planned Parenthood of Connecticut opened up a birth control clinic. They were arrested and they were fined. And then it went to the Supreme Court and they struck that law down. There's a picture of Estelle, who's cute as a button. And then in '72, birth control was made possible even for women who weren't married. And then Roe v. Wade. Now, you might be sitting there saying, why is a GYN oncologist so interested in this? And I'm going to have, there's a path through the woods here, but I became interested in this whole thing about contraception, again, by reading that article. And, you know, birth control pills decrease the risk of endometrial cancer and ovarian cancer. That is true. They did not know that then, though. But all of this piqued my interest in women's health and the importance of it for everyone, regardless whether they have cancer or not. And part of the twists and turns in the road has meant that I've been able to take advantage of opportunities. This is a huge one. About 12 years ago, a woman came into my office for an interview, Jenny Higgins, and the Department of Gender and Women's Studies at UW wanted to hire her. She's a PhD, not a doctor. And she was just meeting with me as chair of OBGYN because her work kind of dovetailed in with a lot we did in OBGYN. And I saw at that moment that, oh my God, we got to get that woman into OBGYN. And I successfully did that. She's 100% in the department. And what she does is research on contraception and abortion. And she and her people are gifted. They have a huge foundation that's been provided to them by an anonymous donor. And the difference they're making for women in the United States, probably in the world, is remarkable. So I developed this interest in birth control. Mostly I was aghast by the stuff that I casually presented here. And so then I looked at this article. It comes out every 10 years by the Guttmacher, which is an organization that looks at women's health all over the world, and the NIH. And between 2008 and 2011, that's the time frame this article's looking at, they looked at the rate of unintended pregnancy, which is the very best metric for women's health in the United States and in the world. And you can see that during this time frame, there was a big reduction in unintended pregnancy in the United States, particularly in teenagers. That same reduction in unintended pregnancies was not enjoyed by all women. If one was black or one was poor, meaning below the poverty line, the unintended pregnancy rate remained remarkably high. And if that isn't stupid, I don't know what is, but it's a fact. And then I started thinking about health disparities. And as a cancer doctor, I've always thought about health disparities. For example, I know that black women have a much higher rate of having the aggressive type of endometrial cancer compared to white women. I know that underrepresented minorities are less likely to receive standard of care for the cancers that they have. So this interest in health disparities was nothing new at all. But I was looking at it through the lens of unintended pregnancy. Then I moved to Wisconsin. So my interest in health disparities just exploded. If you look at infant mortality rate by state, you can see Wisconsin is just kind of in the middle. And actually, Alaska is kind of close to Wisconsin, I would say in the same ballpark. But then if you look at black babies, you can see that Wisconsin's really bad. African American infants are much more likely to die in this state than white infants. And this is another manifestation of that data in terms of a graph. It has gone down, but it's still, black babies die more frequently than white. And I could talk for hours about maternal deaths as it relates to race, but that's pretty much common knowledge. Thanks to Serena Williams and all that came out of that. Black women are much more likely to die in a pregnancy-related event than white women. That's just a fact. And then Wisconsin. I just don't even know what to say. I choose to stay here even after I retire because I feel like the work is important. I'll be working for Jenny Higgins and several other people. Wisconsin is a tough state. But one thing the department's done that I'm really proud of is we've developed a robust diversity, equity, and inclusion committee, and we've accomplished a lot. I'm not going to read these slides to you, but I have to tell you, I'm so impressed with what this committee has been able to accomplish in this department that 10 years ago, I'm embarrassed to say, had very little going on. I'm assuming these slides, you can get them, you can read this. This is a point of pride to me. But remember, I want to keep coming back to the fact that I'm a GYN oncologist. My interest kind of got going on this from a more global perspective when I moved to Wisconsin. But the reality is that, as I said, in GYN oncology, you would have to be deaf, dumb, and blind to not see the health disparity as it relates to socioeconomic class and race. Now, I'm going to switch horses a little bit, and this is relevant to Alaska. So, rural America versus urban. This is a health disparity. If one lives in rural America, you're much more likely to die early than if you don't. And there's a plethora of data about that. You can Google it, you'll see. And I guess it's not totally shocking, but it's ugly in many ways. And I see it as chair, and I see it as a GYN oncologist. So in Wisconsin, 36% of the counties don't have an OBGYN doctor, and the number of physicians practicing OBGYN in the state is lower than the national average, and the female population is growing. That's not pretty. And then you look at Alaska. I got to get there. I told Joni that I'm coming to Alaska one way or another. I got off the track for this meeting, but I've got to come and visit. And, you know, I'm sure everybody in the audience knows you're predominantly a rural state. Isolated, small, rural. That's a lot of land mass for that. 7 of the 29 Alaska boroughs had no practicing physician in 2016. There are 67 OBGYN docs in the whole state, and again, it's below the national average. And same thing, female population's exploding. So rural America, rural Alaska, healthcare, that's a problem. So I've got this interest in health disparities. Wisconsin's rural, not as rural as Alaska, but still rural. And so about 10 years ago, I got a bee in my bonnet about having a residency spot that's only for someone that's going to practice in rural America, preferably Wisconsin. So through a lot of hard work, meaning like, I don't even want to tell you. Well, actually I will. So my husband is a colorectal surgeon, and one morning he tells me when we're in the, we're in the kitchen at 5 in the morning, some god-awful thing, that surgery, pediatrics, family medicine, and psychiatry have successfully secured a rural residency spot that the state is paying for. And I thought, and why would OBGYN not be included in that group? So I casually said, hey, Chip, just can you give me your application so I can take a look at it? He did. I copied it, took out surgery, put in OBGYN. We submitted it. We got it approved at the national level for a specific spot. We're the only one in the United States. The state would not pay for it because we do abortions. So for the first 8 years or something, we figured out how to pay for it ourselves, which was a long story. all legal. Now, so we have this rural residency going. It's fantastic. Right now I'm in the process of setting up a relationship with a Native American reservation in northern Wisconsin to have that serve as a rural residency spot. We have, let me see, no, I took it out. We have 5 sites in the state where our rural resident goes, but we want to add one for the Native Americans because the health disparity as it relates to Native Americans is horrible for the same reason as it is for African Americans. So this program is going well. We're taking our time. I know we're going to be successful. So we got this whole thing set up. And out of the blue came a call from Dean Golden. The state legislature in Wisconsin had a bill that said nobody that works at the University of Wisconsin can perform abortions nor teach them. And, you know, I just want to say that whether one is pro-choice or not, there are situations where having access to abortion will save a mother's life. We all know that. And I respect everybody's opinion, pro or not pro-choice. But the truth of the matter is, there's times when someone's life depends on it. And the second thing is that the government demands that abortion training be available in order to have a residency. So we took on a war room mentality, the dean, myself, and about 20 lawyers. And we had to go down to the state legislature and testify, which was the first time I ever did that. And the bottom line is, what won the day was the fact that if our residency was shut down, then we would lose 1/3 to 1/2 of all the OBGYN doctors training in the state, which would worsen our rural health problem. So all the work we did with that rural residency program was, one, I just think very important, but two, helped us save the day in terms of saving our residents. In the pipeline for training physicians of the future, let's go back to Geonecology. Every gynecologist has to do an OBGYN residency before they do their fellowship. If there's no residency, there's no fellowship. And then that means diminishment of care for women with gynecology cancers. So the downstream effect of establishing the rural residency, which highlighted the importance of our training program, which saved this issue of being able to teach abortions, because it's been illegal to do abortions at UW for 60 years. We work with Planned Parenthood. But this was a big deal. And that's a picture of Dean Golden and myself down at the legislature. And I have to say that in my future life, and I said this when I started, Meg Gaines and I have been joined at the hip on this in so many ways. She is the master of advocacy and patient care, the ultimate master. And I've tried to help her in every way I can because she always steps up for me. In this whole process of advocacy, that's what I'm committing to after I retire. Advocacy around a lot of issues, and you'll see one of the big issues I'm advocating for is in the arena of gynecology, not just abortion and contraception. And getting back to CORE and Jenny Higgins, one of the research areas is the role of expert testimony in Wisconsin regarding reproductive health legislation. Yeah, Jenny helped me a lot with figuring out how to manage that whole scene. And then, going back to health disparities, when I was president of the SGO, one of the perks was like, oh, Laurel, you get to decide the topic for the one special issue of the year for gynecology. So I picked health disparities. It was a fabulous journal. And that's one of the examples I want to mention in terms of opportunities dropping out of the sky. Got a lot of press and a lot of attention. I think the SGO was better for it. Now, I'm going to talk about clinical trials. And I got into this topic of clinical trials as a gynecologist. I'm kind of into it now in terms of the entire landscape of women's health, but it's gynecology. And let's talk about thalidomide. Thalidomide is a drug that used to be used in the early 60s maybe for pregnant women who felt nauseous and had some pain. Well, that pretty much is everybody. 10,000 babies born with flipper-like limbs, phocomelia, and heart defects, none in the United States. Here's a picture of a baby that was exposed to thalidomide. This is Frances Kelsey. She got her master's at McGill in pharmacology. She got her MD, PhD at the University of Chicago, practiced in North Dakota for 20 years, and then she and her husband moved to DC. She joined the FDA, and her first assignment was to review the application for thalidomide in the United States. It had already been approved in 20 countries. The pharmaceutical industry was as powerful then as it is now. And she said, no, we're not doing it. And I saw some of the names she was called. I'm a big cusser, but I'm not repeating them. Heroin of the FDA keeps the bad drug off the market. She got the presidential award from Kennedy. She was a big muckety-muck. And I just want to say, she had job security. She never quit from the FDA. She died at like 101 on the job. God bless her, took tenacity. Now, clinical trials. And the story of how thalidomide relates to clinical trials is this. For a long time, women were excluded from clinical trials. The Harvard Heart Study, risk factor intervention, again, a heart study, the Baltimore longitudinal study of normal human aging, all men, no women. And these were great trials. You know, they were well designed. And the counterpoint to that for women was the Nurses' Health Study, which was just an observational study. The data was kind of better than nothing, but kind of lame. So for a very long time, and this was published in 1991, clinical trials in women, no go. So in 2015, Marcella Del Carmen and myself wrote this article talking about the underrepresentation of women in clinical trials, particularly in gynecology. Now, Marcella is a gynecologist in Boston. I know Meg knows her. And this article talked about the landscape of clinical trials for women, but mostly gynecology. And I just want to say, as I walk through this, every 5 or 10 years, it comes up that women are not represented in clinical trials or research in general. The Institute of Medicine, now the National Academy of Medicine, screams at the NIH, and they say they will do better. Yeah. And this is like women and underrepresented minorities. So this paper was published, in 2014 by Francis Collins, the head of the NIH, who's retiring, and Janine Clayton. And basically it said the reason why a lot of basic science is not reproducible in this country is because they're just using male mice and male cell lines. It's just another example of discussing gender disparity, but I would say that's pretty minor considering the importance of clinical trials and what's happening there. And again, 2016, the NIH said, okay, we'll do better. Even Popular Science got in on it, which makes me laugh. And this is published in 2016. It's not that old. So let's talk about gynecology. Crisis in enrollment to gynecology clinical trials. And this data is about 4 years old. I do have some updated data that reveals it's still in play, but what you can see here is that over 5 years, there was a 90% reduction in enrollment in clinical trials, and there was a 68% reduction in available trials. That is a problem. The only way we make progress in how we treat illnesses in general, but certainly GYN cancers, is with top-level clinical trials. And I'm going to digress for a minute to talk about an article that Ryan Spencer, one of my colleagues, wrote. And there's a million examples of how to look at the disparity in funding for research from the NIH, but this one I kind of like. Disparities in the allocation of research funding to GYN cancers, looking at funding to lethality scores. How many women are dying and how much money is going to those diseases for research. So, looking at the NCI, National Cancer Institute funding across cancer sites using the funding to lethality ratio. And the important metrics in this analysis include the incidence of the cancer, how often it happens, the mortality, how many women die, and how many years of life are lost. When you combine these three factors, you can kind of figure out the impact on a population. For example, in terms of new cases, breast cancer is very common, but many more women die of lung cancer. So, the way this study was done was we used SEER data for mortality and incidence. Years of life lost per cancer came from the NCI database, and same for funding. This is a good data set. This is the best we have. And the math is as follows. The mortality divided by incidence gives the cancer burden in the population, and then person years of life lost the same. So mortality divided by incidence times years of life lost is the lethality. So let's compare ovary to prostate for the obvious reason. And if you walk down the math here, you can see that the mortality to incidence ratio for ovary was higher, much higher than prostate, meaning many more women died who had the disease compared to men who had the disease, prostate. And then if you roll into that, years of life lost in funding, the bottom line is this. There's $85,000 per year of life lost per 100 new cases of ovary, and for prostate, it's $1.147 million per year of life lost per 100 new cases. Just saying. And then if you look at the last 7 years, you can see ovary, cervix, uterus right at the bottom in terms of funding over an extended period of time, 07 to 14. The problem still exists. Lots of strengths. I've already highlighted them. The weaknesses, not all research funding comes from the NCI. Unable to determine the contribution of the cooperative groups, et cetera. But it's inescapable that there's a big disparity in funding for GYN cancers, and it's not getting better. So I thought this would be published in the New York Times. No, it wasn't. It was published in, I don't know what this is, but I was disappointed. To me, this is big news. So where to go from here? So I was very involved with the SGO and the NCI. And then through another organization, I was able to build a platform for not me, it was a group, it was a posse of people, a platform around funding for all of women's health. And we formed the Women's First Research Coalition, which is funded, supported by all the organizations here, including the SGO, to make a united front to the NIH to improve funding for women's research. And, you know, I just want to say that has gone well. We continue. We wrote this article looking at funding for OBGYN departments. When you look at all the different departments in an academic center, OBGYN gets the least amount of funding. And so the summary statement around clinical trials and advocacy for me is alive and well with important work to be done. Even in retirement, I'm intimately involved with this organization that's working with the NIH and the legislature to improve funding, and it is going well. I'm not going to give you the metrics on that, but forward motion, all those organizations are committed to supporting it. So this has been a quick blow through of a very twisty and turny topic that represents my passions for the last 35 years. And I think as patients, Gynecology patients, and as healthcare providers for patients, particularly women, the nidus that's important in this talk is the opportunity to help, because every voice matters, and there's just a million ways to go at it. I've chosen the ways I've described here, but again, the opportunity for advocacy is limitless. So I love this statement. Far and away, the best prize that life has to offer is the chance to work hard at work worth doing. I have had the absolute good fortune to have had that, particularly as it relates to Gynecology in the last multiple decades. Again, I want to say I'm sorry I'm not there with you. I can't wait to hear what Meg Gaines has to say. Thanks a lot.